and adjacent segment degeneration, advanced disc degeneration with spondylolisthesis, scoliosis, stenosis. And also I have a case with a disc herniation at conus level and osteomyelitis and discitis. The first case is a 64-year-old gentleman who works for the government, and he's got comorbidity including diabetes, hypertension, coronary artery disease. It's regular American. He's got no limb length discrepancy, and he's been having some progressive worsening back pain and a bilateral leg pain and a difficulty with ambulation for 2 years. The pain was getting better when he was sitting. He failed medication, physical therapy, and injection. That's his MRI. As you can see, he's got the disc degeneration and spondylolisthesis and quite significant central canal stenosis and neuroforaminal stenosis. And I saw this gentleman first in my office. I recommended minimally invasive lateral lumbar decompression, fusion, and posterior stabilization. Well, I'm new to Seattle, so he didn't listen to me. So he's got a second opinion, and he found a neurosurgeon who was going to do the surgery without fusion. And so he had a laminectomy, fasciectomy, foraminotomy, and L4-5, and he did better. And his leg symptoms went away initially. 5 months later, he started having leg symptoms all over again. Now this time he started having a back pain. So he showed up to my office, and I said, wow, you're a brave man. And he goes, I'm just being practical here. So he asked me to fix him. And I got a new MRI. That's what it shows. Now he's got increased spondylolisthesis, and central canal stenosis remain about the same as a pre-op. And on top of that, because of the increased spondylolisthesis, now he's got destruction of the facet joints. So this is before surgery, and this is after surgery. Before surgery and then after surgery. And you can see marked destruction of the facet. So objective for this case was a spinal canal decompression and a reduction of spondylolisthesis. And I also wanted to stabilize it from the back for better stability. The concern was I wanted to circumvent scar tissue from previous surgery. And given the patient's advanced age and his comorbidities, I wanted to do minimally invasive surgery. So that's what I did. I did lateral lumbar decompression and interbody fusion with a percutaneous pedicle screw fixation. And I used implants that spans from one ring apophysis from the other side for better access. Surgery took less than 2 hours over time. That was negligible. At 3 months, he was and his leg pain away. And he went back to government work. Second case is a 79-year-old gentleman with a comorbidity significant for hypertension and diabetes, and he's been having progressive worsening low back pain and instability and tiredness with the walking. He's been having this for 30 years. He had a surgery done 12 years ago, and he did well for about 2 years, only to have symptoms to recur. And nowadays he walks with a cane, and he gave up pheasant hunting because he couldn't walk any distance, and he was complaining he had no life. And he tried medication, physical therapy, and epidural steroid injection to no avail. That's his x-rays. It's got spondy here. It's got retrolithiasis here, significant disc space narrowing here, and you can tell he had a laminectomy done in the past. That's his MRI. Again, significant disc degeneration and a spondy at 3-4, 2-3, and 3-4 looks almost fused, and he was fused, I found out during the surgery. And a 4-5, he's got a retrolithiasis. This is axial cap at 2-3 and a 4-5. And it looks like he's got the arachnoiditis too. The objective for this gentleman, treating this gentleman with the surgery, was spinal canal decompression with a reduction of the spondy. And also I wanted to stabilize the posterior instrumentation for added stability. And again, just like the first case, I wanted to avoid circumvent scar tissue from previous operation. And given the patient's advanced age and comorbidities, I wanted to offer him something minimum, less morbid. So this is what I did. I performed lateral lumbar decompression and interbody fusion and a percutaneous pedicle screw fixation. And I was able to decompress spinal canal with the indirect ligamentotaxis and the neuroforaminal stenosis also addressed with implant placed that spans from one epiphysis to the other epiphysis. Surgical time was about 3 hours, including turnover time. Again, EBL was negligible. When I saw this gentleman at 6 weeks, he was feeling great, and he stopped taking pain medication 2 weeks after surgery. And he told me that he only had 4 days since operation. And he also reported to me that his balance and posture has improved significantly. And he has some left anterior thigh numbness, which is quite common with lateral fusion surgery. But it was not really concerning to him, and he was improving. And I got an MRI out of academic curiosity, and I couldn't justify with the insurance company, I wanted to get an MRI just because I'm curious. So actually, I had the facility that I'm working to pay for this cost of the MRI. So when you look at it, this is L2-3. This after surgery, that's a spinal canal. And an L4-5 after surgery, and that's a spinal canal too. It doesn't seem much, right? But when you compare that before surgery and then after surgery, you can see the difference. So this is sagittal MRI before surgery, after surgery. That's sagittal MRI, actual MRI of the 2-3 level before surgery and then after surgery. You can see the difference. And L4-5 level is the same thing too. So that's a sagittal MRI before surgery, sagittal MRI after surgery. That's 4-5 level before surgery and then after surgery. So not a whole lot of significant difference in terms of a canal expansion and decompression, but that's really all you need. And you don't have to take the entire bone out and a wide open dura to have alleviation of the stenosis symptoms. So even this much of a difference, the patient did fantastically well. Next case is 72-year-old gentleman who works as a realtor. He's got coronary artery disease, congestive heart failure, hypertension, and diabetes. He had a previous surgery done from elsewhere, and he had a posterior lumbar interbody fusion of the L2-S1 done. His post-op course was complicated with EBL more than 2 liters, and he developed post-op DVT and pulmonary embolism. So he's really gun-shy for further operation. And he started developing progressive worsening back pain, leg pain, weakness, and he had a difficulty walking more than 200 yards. And he had a difficulty to walking, he had a difficulty to driving. A realtor who can drive or walk, and it's not a realtor, you can work. And that's MRI, and you can see that this patient has developed ASD at L1-2, right about the area that we did surgery. And he wanted to have something done because he failed all non-surgical measures. The concern is, I felt that revision surgery for this patient with that kind of history was a way too invasive. And if I'm going to do any kind of surgery, I wanted to avoid the scar tissue from the previous operation. And I wanted to give him something minimum that's going to give him least possible morbidity after surgery. So that's what I did. I performed lateral lumbar interbody decompression and fusion, and I placed intervertebral prosthesis that spans from one ring of apophysis to the other side of the ring of apophysis for maximum ligamentotaxis. And I placed inner spinous plate, and they gave him some flexion extension stability. And again, with a minimum tissue trauma, virtually a negligible EBL. Patient went home within 23 hours, so this was done as almost like outpatient procedure. And he stopped taking pain medication a week after surgery, and he went back to work 10 days after surgery as a realtor. And he told me that the difference that he had with this surgery was night and day difference in comparison to the previous operation. And when I saw him at the 4 months post-op, he was still working as a realtor without any problem. This lady is 9 years old. He lives alone. And funny thing, I moved from Atlanta, Georgia to Seattle about 13 months ago. I never seen so many old ladies living by themselves. And it's, again, I don't understand, but so she's 90, she lives alone. And she has a difficulty with walking, and she walks with a walker less than a block. And she can't stand long enough to fix the middle for herself. And she had a surgery done 2 years ago by another surgeon. And you can see there's the screws, and there's a pig rod in between. And she has this recurrent problem about a year after surgery. And she's been taking medication, doing physical therapy, and epidural steroid injections with no pain relief whatsoever. That's the MRI, and that's previous surgery. That's the level right above. She's got quite significant central canal stenosis and a spondy as well. The concern is she had a revision surgery done in the past. If I'm gonna do, she had a surgery done in the past. If I'm gonna do revision surgery, it's gonna be way too invasive. And I was afraid that her weak bone may not support any kind of implants. And I wanted to do the surgery with a minimum dissection. At age 90, any kind of surgery is a big surgery. So that's what I did. I did lateral lumbar decompression and fusion with a lateral plate fixation at the adjacent segment. And I made sure that I place large implant that spans from one side of the apophysis to the other side of the apophysis, just to make sure that I get a maximum ligamental taxis and decompression of the spinal canal. And I put a plate here, and I couldn't put a 4-hole plate because of all these screws which were in my way. But they gave her added stability. And again, I performed this surgery under an hour and a half, and minimal tissue trauma with a negligible EBL. Patient was discharged. Now she's 9 years old after 2 days after surgery, and she stopped taking all medication after 1 week. She was ambulating without a walker or cane when I saw this lady, and she went back to living by herself 6 weeks after surgery. Any questions so far? This is a 7-year-old former gymnast, and she lives alone too. And she's got diabetes, COPD, and AFib, and she takes Coumadin. And she's been having a progressive worsening right side, more significant left side leg pain, and a weakness for 5 to 6 years. She cannot walk without taking a lunch break, she calls it, after walking for about 10 minutes. And she failed all conservative treatment, and she has absolutely no quality of life. By the way, Dr. Pimenta is not here. I just want to let you know that I actually get a full scoliosis x-ray whenever I see the deformity. I just got this lumbar spine x-rays, so you can concentrate on the pathology better. So this is the MRI. It shows a multi-level disc degeneration, 2, 3, 3, 4, 4, 5, and 5S1. And the worst area was the 4, 5, where she has really severe central canal stenosis, lateral recess stenosis, and neuroforaminal stenosis. And she's got reactive bone change here and here too. The objective surgery, of course, is decompression of the spinal canal and reducing the deformity. And also I wanted to address L5S1 neuroforaminal stenosis, and I wanted to put posterior instrumentation for added stability. Again, because of the patient's advanced age, I wanted to do the surgery with a minimal dissection. This is what I did. I performed lateral lumbar decompression and fusion of the L2, 3, 3, 4, 4, 5, and minimally invasive transpyramidal lumbar interbody fusion and L5S1, and did a minimally invasive segmental instrumentation. So that's before, after. She felt great 3 months after surgery, and she's not taking any pain medications. She had a complete recovery of the motor function, and she's dating again. Next case, this is a 72-year-old lady with a diabetes, hypertension, peripheral neuropathy, anemia, glaucoma, obstructive sleep apnea, and she's a former smoker. She used to smoke for 50 years. She quit about 3 years ago. She's got chronic back pain and inability to walk distance. She's been having this problem for years. And she cannot walk more than a half block. And she felt that every time she tried to walk, she's walking sideways. Again, the usual medication, physical therapy, epidural steroid injections didn't work. AP x-ray, lateral x-ray. This is MRI, and here she's got central canal stenosis, and she's got central canal stenosis, a lateral recess stenosis as well, and quite significant facet arthropathy. Objective is a decompression of the canal and a reduction of the deformity, and also I wanted to address L5S1 neuroforamen stenosis, and with a minimum invasive surgical technique. That's her. She undergone lateral lumbar decompression and fusion and transforaminal lumbar innerval fusion with MIS technique at L5S1 and segmental instrumentation with MIS technique. I was able to decompress central canal and neuroforaminal stenosis utilizing ligamentotaxis. I was kind of concerned about this case because she's got quite severe facet hypertrophy. When you have a severe facet hypertrophy, usually ligamentotaxis doesn't work that well because you kind of have to unlock the facet. So I was very happy that actually I was able to do so. And again, I think the key is putting a cage that spans from one side of the ring cortex apophysis to the other side, so you can actually increase the distance between a vertebral body above and below. So this is after surgery AP and lateral. AP X-ray before, AP X-ray after. Lateral X-ray before and lateral X-ray after. She had a mild dysesthesia of the anterior thigh about when I saw this patient 2 weeks after surgery, and that has gone away since then. And she stopped taking pain medication 4 weeks after surgery. When I saw this patient at 6 weeks, this time she was walking straight 3 miles every day. She has gained about 1 inch of the height, and she was very happy with the surgical outcome. Now, this lady is a 58-year-old.
We had one question.
Oh, go ahead.
Hi, excuse me. I was just going to ask those last couple cases. I noticed there were, you didn't. I was just wondering if you could share your thoughts why you didn't put pelvic screws in here.
Say that again, please.
Why you didn't put pelvic screws in? Just share your thought process.
Why did I not put a pelvic screw?
Yeah, in this case and the case before.
She's so old. Why do you want to put pelvic screws?
I'm just asking his thoughts.
I'm just kidding.
Well, you mean why did I put a pedicle screw into the sacrum?
No, he's asking why not pelvic screw.
Oh, why not pelvic screw? Okay. In order for me to put a pelvic screw, I'll have to open it. And all these screws are placed with a percutaneous pedicle screw fixation without actually doing muscle dissection. And these people are old people. They are age 80s.
No,
and I wasn't going to open up and cause the bleeding and increase the morbidity. And besides, this construct is very stable, and I didn't think that putting an extra fixation at the pelvis was all that necessary.
What about just laminectomy?
I'm sorry?
What about just, instead of fusing on instrumental, just a laminectomy and
if I just laminectomy
and follow the curve? And because to me, I mean, you don't have the 3-foot standing films, but if this patient was not on sagittal balance, it could be a big deal, 72 and fuse it flat or something. I just,
Sure.
trying to create some controversy on the audience.
and Juan, you are good at that, I know. Yeah. But anyway, as I mentioned previously, these are the patients that I get full scoliosis x-rays. I just didn't put it in because I want you to see the concentrated view of the pathology.
Yeah, because look like the next case you have the 3-foot standing films on the next one.
Right, because that was idiopathic scoliosis.
Yeah.
Anyway, this patient, why didn't I just do the laminectomy and be done with it? Well, in order for me to do laminectomy, I have to do a tissue dissection. And then patient's gonna bleed. Surgical time is gonna increase. Now that surgery, the lateral part of the procedure took less than 2 hours. Percutaneous pedicle screw fixation took about an hour and a half. And you do the laminectomy, sure, you might be able to, if you move quick enough, you might be able to do the surgery within the combined time of the 3-4 hours, but at what cost? And again, you open up, then you increase the chance of infection and bleeding, and then potential morbidity. And I didn't think it was appropriate surgery for people of this age group with that kind of comorbidity.
The lateral interbody used to do how many levels could you put
In a body?
the lateral interbody? Yeah.
Sure. In this case, she has 1, 2, 3. That's lateral interbody fusion.
Might also, another option is consider two-level L45 and L5S1, getting and do it standalone, or even with maybe invasive posterior fusion and fixation.
Sure. I mean, you can do a lateral anterior approach, and that's a perfectly good option. But again, is that opening up the peritoneum on patient who's 87 years old? Oh, retroperitoneum?
Yeah, well,
Oh, you mean don't put any screws?
when you open a retroperitoneum here, you standalone case, you get correction in the room. You can open it with posterior.
The reason why I was able to get a correction of this magnitude is because I was able to put a cage that spans from the one ring apophysis to the other. And then if you put a cage from anterior approach, it's going to sit in the middle of the vertebral body. You are not going to be able to correct deformity correction with that much. You're certainly not going to be able to create any ligamentotaxis, which will decompress spinal canal and neuroforamen. You could. Sure. There are many different ways of taking care of the problem, but if you have a better way, why not take care of it? Why not use it?
Did you go on the concavity?
Would I go on the concavity?
Yeah, did you go on this one? Did you go on the concavity?
This patient, yes. I approach from the left side.
They're coming after you, Sean.
They are coming after you.
There's just one option available.
Yeah, sure. Yeah, again, as a spine surgeons, we try to have many different options of taking care of the same problem. And I think it is my duty, our duty, to offer the patient, especially an elderly patient with a significant comorbidities, to offer the minimum available, most advanced techniques that you can offer for these patients.
Just a quick question on the interbody.
I just think it's good to remember this is maybe minimally invasive, but maximally expensive compared to laminectomy.
It is expensive. I don't disagree with that. However, if I were to do open procedures and if I kept the patient in the hospital days after days, and if you have to transfuse this patient with the blood, and again, hypothetically, this patient doesn't develop any kind of complications associated with the prolonged surgery, you wonder how much money you actually have saved by doing so.
So you talked a lot about ligamentotaxis.
Yes.
And do you have any paradigm or any pearls for people of when you might be able to achieve good indirect decompression and when you feel that you have to go back and open it up posteriorly with a laminectomy?
By and large, if the patient has a quite severely arthritic facet joints, and you have to tell the patient that there's a chance, about 10% of the chance, that we have to go back and do more laminectomy. But a lot of times, people love that odds. If you have a 10% of the chance to go back to have a more laminectomy to take care of the problem, when you think about reoperation of the patient who had a A-lip or T-lip or P-lip, that chance of a reoperation probably is higher than 10%. I don't have the data. So I tell the patient when they have a severe spondylosis and a facet arthritis and a severe central canal stenosis, I give them a warning. I'm going to offer you a minimally invasive surgery because of your age, because of your bone quality, and because of your comorbidities. But there are about 10% of chance I'm going to have to take you back and do some laminectomy later in the future. And a lot of times patients accept that just fine without a problem.
Quick question. With the selection of interbody grafts, did you use rectangular or scoliotic ones? And what would you say was a relative contribution to incremental correction between the lateral approach and then the posterior?
I didn't quite understand the question. Would you repeat that?
Sure. For the cages used on the lateral approach, did you use standard rectangular ones, or did you use
Yes.
ones that are specifically for scoliosis that are somewhat trapezoidal?
Yeah, we have lordotic cages available too. But what I've been doing in my practice is, if I want to give the patient more lordosis, I tend to put the cage more to the front part of the spine. If I want to create more ligamentotaxis, and then if I want to open up central canal stenosis, neuroforamen stenosis, I tend to place cage little back. But yes, that lordotic cage is available. But in general, I just use a parallel cage. I just change the position depending on what the emphasis of the pathology correction is. Okay. This is a 58-year-old lady who works as a tour guide. She works around that Space Needle, and she has a known scoliosis, and she's been having chronic back pain for many years. She couldn't have a surgery done because she smoked cigarettes 2 packs a day, and she started having this progressive worsening severe right leg pain, 10 out of 10, and weakness in addition to this chronic back pain that she's been having. She couldn't walk more than 10 steps, and it's been going on for 6 weeks, and it was getting worse, and she couldn't work. And when I saw this lady in my exam room, she was just crying. So that's the MRI, and there's a disc herniation at the level of the conus, and putting a pressure on right side of the conus medullaris. What am I going to do? Am I going to do posterior discectomy and recheck conus medullaris? Probably not. And am I going to do facetectomy and a laminectomy alone? She's going to get some symptom relief, but it's not going to address disc herniation. And if I have to do a wide enough laminectomy and facetectomy, probably it's going to make her scoliosis much worse. Anterior decompression, am I going to take this lady for disc resection? And with the anterior approach, I didn't think it was such a good idea. So this is what I did. I approached from the side, and I did lateral decompression and interbody fusion at L1-2. And I was able to do a direct decompression through a thorough discectomy and indirect decompression with a ligamentotaxis to follow by placing intervertebrate prosthesis. I did not put any hardware here because I figured this lady probably going to need some surgery later on to correct her scoliosis. So I wasn't going to make things more complicated for me. When I saw this lady 1 week after surgery, she only had a mild tingling sensation on the left side. 8 weeks post-op, she had no complaint. She told me even chronic back pain got better. And 1 year post-op, last time when I saw her, she was going to the Nepal for backpacking, but she's still smoking. So I don't think I'm going to operate on this lady anytime soon.
So in that case, I mean, I certainly agree with the idea of if her scoliosis is not part of her symptomatology, and you can certainly ignore the scoliosis, it appears that her symptoms were based on that single level herniated disc. But why not do a minimally invasive discectomy on her? You know, you could even drill, down the pedicle on that side, and you don't really need to instrument her. And her smoking, is still a problem, even though you've done one level. And now without instrumentation, I would think her pseudoarthrasis rate would go up. And in addition, when you fuse her, aren't you worried that you're going to actually make the scoliosis worse by fusing her as opposed to doing a laminectomy or decompression?
I didn't think that I was going to make her scoliosis any worse because the level that she had disc herniation was right here. And fusing this, I didn't think it was going to affect overall dynamics of the curvature that much. Another reason why I put an implant in there is because although I did minimally invasive discectomy, I was thinking, what if I didn't get the entire disc out? At least I wanted to have a ligamentotaxis as a backup, just to really clear out the canal. This is 87-year-old, another old lady living alone, and she's got a long list of comorbidities, diabetes, congestive heart failure, AFib, hypertension, COPD, peripheral neuropathy. And she's a 2 cancer survivor from breast cancer and vulvar cancer. And this lady developed discitis after stuffing her toes on the floor. And she's got osteomyelitis of the big toe. And a podiatrist debrided it and ultimately amputated it. And discitis became osteomyelitis, and osteomyelitis became epidural abscess. And he was being treated with antibiotics because no surgeon in town would touch this old lady with these problems. And she started walking all together, and she was wheelchair bound, and she has been living in a skilled nursing facility for 2 months. And infectious disease doctor obtained a new MRI, and he showed actually epidural abscess got a little better, but the discitis and osteomyelitis has gotten worse. And she was not getting up from the wheelchair anytime soon. So infectious disease doctor deemed that the antibody treatment was ineffective. So this patient came to me. And this time the MRI showed left psoas involvement and also rachinoiditis as well. So this is a liquefied disc at L1-2, destroyed the L2 vertebral body. 87 years old with all kinds of comorbidities. I wanted to debride the infected tissues, vertebral bodies, and the disc, and the psoas muscle. And I also wanted to decompress spinal canal at L1-2. And since I'm there, I wanted to take care of L2-3 as well. She has a severe spinal stenosis there. And also I wanted to restore her spinal stability. I wanted to do all that, creating a minimal tissue dissection and morbidities, surgical-related comorbidity for this lady. So this is what I did. And I approached the spine from the side of the infection of the psoas on the left side, since I had to go down there anyway, and I was able to debride psoas abscess. And I was able to actually perform partial corpectomy. And I basically curate it out, and with a Ranger, I just chipped up whatever that appears to be infected. And what I did was I took a cage, a 14 millimeter PMMA P cage, and I packed it with the tauramycin PMMA and put it in. And I flipped the patient quickly, and I performed posterior laminectomy of the L1-3 and did an open screw fixation of the L1-3. Why do the lateral approach? Because if I were to do the corpectomy and complete discectomy from the front, I thought it was going to be more morbid. And by approaching from the left side, it gave me an opportunity to debride left psoas. And it also gave me an opportunity to improve the deformity of this patient. And by doing the lateral approach, you can actually take advantage of the only uneroded part of the vertebral body, the hardest part of the vertebral body, which is ring apophysis. All the other stuff basically has been destroyed, but she still had an intact ring apophysis. And I was able to take advantage of that with a lateral approach. You cannot do that either with a postural approach or anterior approach. Why do postural open decompression? In this case, ligamento-taxis does not work because all the tissue has been destroyed. So even if I put a large cage in there, I'm not going to be able to clear the spinal canal with a ligamento-taxis. So this is one of those cases you actually have to go in and decompress it with open procedures. And that gave me a chance to take care of the adjacent level at the same time. You may wonder, she's got crappy spine. Why not take care of the rest of the spine? You don't want to do that when the patient's infected and with that kind of comorbidities in age 87. 3 weeks post-op, she was ambulating with a walker. Actually, she finally got out of the wheelchair. And 8 weeks post-op, basically, she was feeling great. There was no sign of active infection going on. 3 months post-op, she was ambulating without a walker for a short distance. 6 months post-op, she went back to pre-morbid state, living alone in an apartment. This is another or single lady living alone, 69-year-old hypertension, DVT, pulmonary embolism.
Is there a trick?
You know, funny thing is, I've been saying the same thing. When I was in Atlanta, my Medicare patient population was made up 13% of my total patient population. Ever since I moved to Seattle, I see about 60% of the Medicare population here. I think it is because the people with private insurance all go to Dr. Oskunian. So I only get this lonely single old ladies. Anyway, she has hypertension, DVT, and a pulmonary embolism, chronic renal failure with associated anemia, glaucoma, and obesity. And she's been having chronic back pain for years. And she had a recent, meaning that past year of the exacerbation. And she also had radiating pain as well. And she tells me, I'm poor, but even if you pay me $1,000, I cannot walk around the block. That's what she said. And again, prolonged standing made her back pain so worse, and she could not do house chores either. That's an MRI, spinal stenosis worse at L4-5 level, and she's got bone edema and the neuroforamen stenosis L5-S1, and again, moderate spinal stenosis at L3-4. Again, the objective is a decompressing spinal canal and reducing the spondylolisthesis and addressing L5-S1 neuroforamen stenosis and stabilizing it. Again, all this with a minimal tissue dissection. I perform lateral lumbar decompression, inner body fusion, and indirect decompression of the spinal canal and neuroforamen with implant that spans from one ring apophysis to the other ring apophysis with a maximum ligamentotaxis. And I did minimally invasive transforaminal lumbar inner body fusion in the L5-S1. Now, when I saw this lady, it looked like this cage was slightly more posterior than I wanted to see. And she was doing great until I showed this x-ray, and I wasn't gonna hide anything from her because if I hide, someone's gonna pick that up and said, Dr. Keem did this, right? So I showed this to her and I told her, well, you're doing great. I don't think there's any problem. Chances are this is not actually putting any pressure on the nerve. And all of a sudden she goes, no, I wanna know. So what do you wanna know? Well, if it is that far back, then I want you to push it to the front. So it was a great chance for me to get a post-op MRI. Usually you don't get to get a post-op MRI, right? This time I could get a post-op MRI using insurance money. And then it was all in front of the PLL. It was not in the canal as well. But most remarkably, I saw this. That was L4-5 level, where she had a really severe central canal stenosis. Let me compare this for you. Pre-op, post-op. It's a lot better. And of course, you got some metal artifact here. Pre-op, post-op. Look at the canal diameter. And I also noticed that facet distraction, which is quite significant from pre-op MRI, is gone because with the ligamentotaxis, I was able to bring the spine back to what it was. So now facet joints are together without being distracted. She had no back pain, no leg pain, and she stopped taking the medication when I saw her 2 months post-op follow-up, and she was ambulating more than a mile, this time just for the love of walking, not for the money.
I have a question.
Yes?
On the pre-op MRI, it looked like the L5-S1 foramen was pretty normal on that case.
Here?
Yeah, on the pre-op MRI.
That's pre-op MRI.
Yeah,
That's a pre-op MRI. That's post-op MRI.
I mean, the L5 nerve root is got lots of room around it.
Here.
Yeah.
Well, that's the level that she had a central canal stenosis. And I don't have an axial view, so I cannot really substantiate my claim. But the radiologist read it as severe neuroforamen stenosis of the L5-S1.
Okay.
I'm not sure about that. It looks like you're getting a little adjacent level already. That was the view of this actual.
Which one?
Just post-fusion. But maybe it just looks like that, but.
Sure. Go and point it out. What are you talking
Oh,
about?
I was just saying, do you think her pain, you did an MRI because she was still having pain or because?
No, I did an MRI
Just
because
to look
when
at
I
the
showed her
cage.
this x-ray,
Oh,
when I
okay,
showed this
got it.
x-ray, I told her everything looks good. And here, I think the cage looks slightly
Okay,
posterior.
so it wasn't because she was hurting after?
No,
Okay,
no,
got it.
but she was doing fine until I
Okay.
showed this x-ray and pointed this
Got it.
out to her. And all of a sudden, she said, well, I want an MRI.
Yeah.
I want to make sure that my nerve is not crushed. So I have to oblige. 69-year-old gentleman with a coronary artery disease, hypertension, diabetes, diabetic neuropathy, AFib. He's taking Coumadin. He's got 6 sinus syndrome. He's got a pacemaker, peripheral vascular disease, asthma, obesity, GERD, and a former smoker. And he's got the chronic back pain and a leg pain and a numbness and difficulty walking for years. And he says he cannot walk more than 200 feet. And he tried, exhausted, failed all of non-surgical measures. That's his x-ray. I don't have an MRI because he's got a pacemaker. And you can see that there's a myelographic block there. L in the disc. Again, I wanted to decompress the spinal canal and reduce the deformity. And I wanted to do this by bypassing all these comorbidities without causing significant surgical trauma. Intraoperative, this case was a little challenging because I thought I was able to bend the body and then access disc space of the L5S1, L45, but his spine was so rigid, I couldn't do that. And I tried to bend it a little more, and then neurophysiology monitoring tech says we lost SSCP. So what do? So I had to unbreak the bed, and I had to do the surgery without flexing the water table at all. We had angular instrumentation here. So I docked the retractor oblique way over the iliac crest using angle cob elevator to detach disc from the end plates. Triangle trial, box chisel to remove the disc. Remove the disc material with angle pituitary, and a trial with angle trial. And I was able to put an intervertebral prosthesis even for the patient whose spine is too inflexible to bend and has a high crest. AP and lateral view. That's post-op x-ray. His back pain was continuously improving. When I saw the last time, he had no more numbness or weakness in the leg. And he told me that he walked more than he ever walked in his life. So the indication for the lateral lumbar linear body fusion decompression broad and still growing, I think. The learning curve is stiff, but I think it's short. And it fits well for most of the practice. It fit well when I was in Atlanta, when 13% of the population Medicare. It fits me well when my Medicare population is 60%. Again, if I have any pearl to share with you, make sure you palpate and visualize. Do not ever do the surgery blindly when you're not sure. And then you have to look at it and you have to palpate it. Thank you.
See that we are through the olive.